Hello and welcome to this episode of Sharp Scratch. This is a podcast brought to you by the BMJ where medical students, resident doctors and expert guests come together and discuss all the things you need to know to be a good doctor but that you might not get taught at medical school. My name's George and later this year I start my final year at Warwick Medical School. This year, however, I've been working at the BMJ as the editorial scholar, looking after all the content the BMJ student has been producing. Today we are joined by two panellists, Judy and Elisabeth. Would you both like to introduce yourselves?
Hi, hello, my name is Judy and I'm a fifth year medical student.
And hi, my name's Elisabeth. I'm also a fifth year medical student at UCL.
Thanks so much. I'd also like to welcome our expert guest today, Laetitia Zeeman. Could you tell us a bit about yourself too, please?
I'm Laetitia Zeeman, Principal Lecturer and Researcher working at the Centre for Transforming Sexualities and Gender, University of Brighton, and I work mainly in the field of gender, sexualities and health. And the research aims to address the health inequalities of lesbian, gay, bisexual, trans, queer and intersex people to promote greater health equity.
Amazing, thank you so much. I'm really pleased to have all three of you with us today. Gender equality and discrimination faced by those from minoritised genders and sexualities has been shown to impact health outcomes, with research showing that when it comes to the healthcare of women as well as LGBTQ plus patients, healthcare professionals often have gaps in their confidence and knowledge. In this episode, we're going to talk about the importance of taking an inclusive and an intersectional feminist approach to studying medicine and what medical students and doctors can do to begin addressing these gaps. So, Laetitia, my first question for you really is, could you tell us a little bit more about the work that you do and why it's important for medical students to know about this?
When we think about health inequalities, research and education, we often draw on the work of feminist and queer theories. And this is really important to consider in the context of healthcare. I think because there are pronounced health inequalities LGBTQ plus people experience compared to their same gender heterosexual peers. And health inequalities research and education has become, I think, this greater awareness of it and the importance of it that's developed over the last 10 or 20 years. So there's a groundswell around awareness of health inequalities of LGBTQ plus people.
Thank you. And one of the words that I think comes up quite often is intersectionality and kind of taking an intersectional approach to queer theory and feminist theory. And I was wondering if you could explain that a little bit.
Yes, so when we think about intersectionality, we consider people in the broader contexts of their lives. So people carry certain markers of difference like age, ethnicity, gender, sexuality, social class, disability, etc. And where more than one of these markers intersect, people may experience hardship. So, for example, in a clinical encounter where you work as a medical student, an older bisexual man may present with anxiety and he's from a minority ethnic group. So markers of difference for this person may intersect to position him as other or non-normative. There are normative ideals in society, often reflected in binary oppositions. So, for example, health and illness, gay and straight, able-bodied, disabled, or younger people and older. And the first marker is often preferred over the second to create a normative ideal. So, for example, the normative ideal in society may be heterosexual, able-bodied, younger, and for some people, these ideals might be unattainable, and as a result of that, they become different or other. So, where markers intersect, this may impact on the person seeking health status. So, for example, for our older bisexual man, his age as an older person, sexual orientation as bisexual, and ethnicity from a minority ethnic group may intersect. He may have experienced certain forms of marginalization that may impact on his health status. He may, for example, experience discrimination both as a result of being LGBTQ plus and also his ethnic origin. So in clinical encounters, he may experience, for example, forms of marginalization or discrimination that we have to be aware of, because health professionals can address these forms of marginalization.
Elisabeth, Judy, I was going to ask you a little bit about kind of your experiences of teaching on this.
I think about intersectionality a lot in placement and basically the factors that are showing themselves in the patients in front of me. But I think as well, I find it really tricky kind of within the medical mindset of studying. It's very like yes or no, diagnose, this is a value that therefore if this is above or below XYZ person has a disease. And I find it two very different ways of thinking. And I think both are equally important and necessary. But I think I find, like, as I've gone through medical school, I can feel the bit of my brain that's there for the kind of algorithms and the yes, no is becoming much more developed. And I wondered kind of whether Laetitia or Judy or George as well, whether you guys have advice about developing that idea to think about things intersectionally and think about the multiple kind of cultural and social factors at play, while also, and yeah, deepening that level of thought and reflection, while also learning to diagnose in the kind of tick boxy fashion that sometimes medicine can be.
I think that's definitely something that resonates with me. And a couple of weeks ago, I was kind of thinking a lot on a topic like this, mostly because I was noticing that within healthcare, just from like my experience working on wards or like my experience working as a vaccinator, there were instances where I would experience certain microaggressions, and I didn't really know how to handle those situations. And I found myself in a position where I had to educate other members of staff on things that potentially people haven't come across before. And even within medical school, kind of like how Elisabeth was talking about, we are taught quite a strategic way of diagnosing, but there are some things that, outside of classroom do need to be spoken about. And I was quite interested in this idea of, so there's a sort of a test online called the implicit association test. I don't know if Dr. Laetitia has come across this before, but I thought it would be really good to include in medical school or like sort of medical training, because I do come across different people of like all different backgrounds, and people do tend to have certain ideas surrounding things that they are not quite aware of, and it does sort of trickle down into the way that we interact with patients of certain demographics.
Yes, I think implicit bias is really an interesting concept, isn't it? Because inadvertently we may carry implicit bias, and it's a little bit like when we work as health professionals in clinical practice, how do we see the blind spot behind our own head? And I think sometimes a tool might help us to become more aware of biases that we might have internalized inadvertently. And then how can we become aware of it, but then also try to act in a way in clinical practice that's inclusive and appreciative when we encounter people who might have experienced different things in life or come from a different ethnic or cultural background to what we are.
Do you know what? It's really interesting. When Judy mentioned that, I was thinking one of the things that I feel is a barrier when talking about implicit bias, and this has been in my experience pre-medical school as well, is that when you mention bias in teaching to people, sometimes people get a little bit defensive because they don't want to think that they could be biased in their practice at all. So I struggle with that, knowing how to talk about it. And one of the things that I've struggled with is like when we have conversations around white privilege, sometimes you'll have white working class students say, well, I don't feel like I'm privileged. So I find that kind of concept a bit alienating to me. And I think sometimes the same happens when you mention bias, particularly in healthcare practice, because most medics are going to say, I treat all patients the same. I will treat all patients the same across the board. I don't want to acknowledge that I might have bias in my thinking. So I think implicit bias sometimes, in my experience, frightens people a little bit. But I can relate with Judy as well about feeling like sometimes the experience of microaggressions as a student who is from multiple kind of minority groups, sometimes I feel like the onus ends up being on me to teach other healthcare staff potentially. And I can think of one particular occasion when I was in theatres and I was just observing a C-section for the first time. And after the C-section, some of the theatre staff were saying, "Oh, I don't understand all these transgender people. It's, it's a load of rubbish. It's they swore actually." And I was like, "Oh, either I stand here and feel really uncomfortable about this conversation that they're having about the potential for more transgender children being in the world," was what they were talking about. "Oh, none of these babies will be transgender," was kind of the implications of what they were saying, and it's kind of down to parenting and stuff. It's really difficult when you think either I stand here in my discomfort and I don't say anything, and it's the same for, when people say things that are kind of racial stereotypes and you're from that ethnic group, and I'm quite ethnically ambiguous, so people don't always necessarily know where I'm from, so they might say something about a group.
Yes, that's a very good point. And it links well to what both of you were saying, George and Judy, in terms of, so when we witness something happen in clinical practice, and it might be, for example, discriminatory, or people might say something that speaks to some form of stereotypes, maybe around gender or ethnicity or race, which often happens in practice. What do we do? Do we call out the behavior? And then if we say something, people might become defensive and shut down, or do we invite people into a conversation? And there's a subtle difference there, isn't there? So how do we try and create an opportunity to have a conversation with people, to notice what's happening, and then to invite them to engage in order to be able to maybe help them realize what's happening, and then to create a joint understanding of how can we speak about people in a different way that's maybe more respectful, more appreciative, more inclusive.
So, like, from my experience working in the NHS, we have had like training modules and stuff where I think we did one specific module about microaggressions, and I thought, like a student, I thought it was really interesting, but it was extremely short. It was probably the shortest module, and it only really touched on like very surface level microaggressions.
I often wonder when we are in clinical environments, also in the classroom with students who are learning to become health professionals or doctors, if we work with maybe case scenarios or practice narratives where we give an example of something such as that occurring, is there a possibility then to maybe unpack the scenario with people to be able to make sense of it together? And that sounds as if it's fairly easy to do. However, I think the conditions for constructive learning are so important in terms of, so if we do have a case scenario or a practice narrative that we unpack, do people trust in one another enough to be able to speak freely and to be able to maybe share some of their examples of what they've experienced in practice?
I think the idea of sort of like working as a team, I think that's really good. And I think kind of like George was saying earlier with the implicit sort of bias test, people would feel like maybe embarrassed or sort of quite defensive. And in terms of like the implicit bias test, just sort of to note, it's sort of, I think it was created by one of the top universities in America. So it's very like America focused in terms of like the way that they use language, and sort of more so the type of discrimination people would face would be a bit different. They call it the implicit association test, and sort of like kind of tying it to what you were saying in terms of like working as a team. I think potentially having a two-tier system where people do this like implicit association test privately. You're not having to tell people what your results were. You're not having to sort of share that piece of information, and then sort of like encouraging people to do their own research behind sort of their results, and then having a system where people come together and then talk as a team might help to sort of alleviate some of the fears around people wanting like not to be labeled as biased or feeling a little bit of shame surrounding that.
Yeah, I was actually quite struck about you talking about the implicit bias test, because I think actually my uni got us to do it in either first or second year quite early on. I completely agree with you. I think it really shaped my thinking and made me understand a lot of bias is to do with human brains taking shortcuts and heuristics that people don't intend to. And I think it really helped. But I think I've also been quite interested in seeing how the teaching has shifted between preclinical and clinical. I don't know whether your guys' courses are similar, but I think I felt that I had maybe a lot more discussion around kind of gender and race and class kind of earlier on in the course. I think obviously it's harder going into clinical years to have as much control over what students are learning and engaging with. But I think as well, like George was talking about in surgery and kind of being more in the hospital environment, there's quite a lot of seniors with some views that I suspect a lot of us wouldn't agree with, that then gets voiced and kind of, I guess, hidden curriculum kind of vibe, like we're then picking up on this and it's not being addressed. I also think as well, probably the fact that I had a lot of teaching, especially around race, but also around gender, shows also as well, like how the political climate has kind of changed over the last 4 or 5 years, in that like coming out of the pandemic, I think people were very aware of intersectionality and how these risk factors overlap and things like that.
I would say I think medical schools are getting better at teaching these things and implementing these as part of the curriculum. I think what is hard to control are the experiences that people have once they're out in trusts and they're kind of out in the wild. And of course, you come across people who might not have, similar views on things, particularly on kind of queer health at the moment. I think that's particularly divisive in medicine. So I think it's really difficult, but I do think that medical schools have a duty to look after their students, and when they go out in trusts, to make sure that, if they are coming across these things and they are coming across attitudes that are discriminatory, that they feel like they're supported in speaking up about it and coming forward and saying this has been my experience. So I think it's about fostering an environment that is inclusive from preclinical, from day one, where students feel like their voices are being heard and that their voices and their experience matter, whether it's in the classroom or on the wards. I feel like a lot of the time we speak about it in quite like hypothetical terms, and we don't actually learn about, well, in my experience, we don't necessarily learn about the actual like disparities when it comes to particularly like LGBTQ plus patients. I don't think we learn kind of why it matters to learn about it. People think, oh well, I just treat every patient the same, but they're not actually aware of kind of some of the health inequities.
Yes, so that the health inequalities of LGBTI people, and by LGBTI I mean lesbian, gay, bisexual, trans, intersex, and then plus everyone else that's kind of gender or sexual orientation minority people, are well documented in research. So systematic reviews of research undertaken over the past 15 or more years show that, for example, lesbian, gay, and bi people experience worse physical health compared to the general population. So, for example, gay men showing increased incidence of long-term conditions such as, arthritis, spinal problems, chronic fatigue syndrome, gastrointestinal problems, liver and kidney problems. And lesbian women have a higher incidence of polycystic ovaries compared to women in general. For example, in these groups, bisexual people's health was poorer compared to lesbian and gay counterparts because they experience minority status in both LGBTQ plus communities, but also in heterosexual communities. And we also have evidence of LGBT people experiencing higher rates of developing certain types of cancer at a young age. So, for example, gay and bi men are twice as likely to report the diagnosis of anal cancer, and LGBT people are more likely to report enduring psychological or emotional problems compared to the heterosexual population. And bi, trans, and intersex people show greater inequalities in mental health compared to their lesbian and gay counterparts. And LGBTI people are also more likely to experience unfavorable experiences around communication with health professionals. So we know from research that the causes of these health inequalities are as a result of a combination of cultural, social, and political factors leading to experiences of things such as minority stress, discrimination, marginalization, homophobia, transphobia, etc. So, for example, we know in countries where LGBTI people have had legal protection, the incidence of anxiety and depression over time has decreased. So we know that there are certain measures that we can put in place to help support the health and promote the health equity of LGBTI people.
I was aware of things like social determinants and inequalities and things like that, but I have been struck that I think it's kind of more of the gender and sexuality side. It will be referenced, but more in passing as compared to a lot of the other risk factors. And I'm not entirely sure of all the reasons of that and wondered if, Laetitia, you had some ideas about that.
A lot of what Dr. Laetitia was saying, these are like new to me. I've never heard of any of this information before. So I think it kind of is striking me that I'm like very close to the end of my medical training and I'm like only hearing about these sort of things like now.
I think over the last 15 or 20 years, there's a groundswell around research and publication of research findings. But there's much more, I think, I agree with you, Judy, that we can do to inform curricula, and maybe more we can do around raising awareness of health inequalities and how they can be addressed for LGBTI people. I think George spoke earlier about people's specific health needs and how important it is that we consider people so that particular population groups might be at risk of experiencing greater inequalities. And I think there's more that we can do in the curriculum to focus on smaller population groups that might have higher incidence of certain health inequalities.
There's something as well I think I find a lot as well in terms of when we've had teaching about health inequalities is I do think people go into medicine because they want to help and treat people. And I don't think anybody wants to go into medicine because they want to hurt people. But I think I also find that discussion around health inequalities, not all students, but I think I find some students then shut down, I think, because it's such a big issue that we can't fix. Like, if anyone even attempted to tell somebody that their culture or their sexuality should be something that would be need fixing, that would be horrific. But I think it's something that people struggle with a lot is this idea that they're treating a patient, but they can't fix the underlying structural causes of this person's illness.
But I do think where we can make a difference is in our clinical encounters with patients or service users. If we communicate in a way that's respectful, appreciative, non-judgmental, every clinical encounter can make a difference. So, for example, if we think of LGBTQ plus people, just asking people how do they identify? So, what pronouns do they use? Trying to use gender neutral language. So, for example, trying to ask people, would you mind sharing the details of your partner rather than saying, do you have a husband or a wife? So there are certain things we can do in each clinical encounter that can help to address people's experiences of discrimination and marginalization that some people might experience in clinical practice.
And can I ask, Laetitia, I think one of the things that I experience people pushing back on sometimes is they're saying, well, if I'm more inclusive for people maybe outside of the gender binary or I'm not assuming patient sexuality, is that then alienating to other patients or does that not? I guess I'm kind of playing devil's advocate a little bit here, but like some people might push back and say that they don't think that's important for all people's health and it's just a small portion of part of the population that it would impact, but that for other patients it would be problematic or alienating to ask, I don't know, someone that they perceive to be a woman who's in their late 80s and saying, what are your pronouns and things like that might be alienating. That's the kind of things that sometimes people have said to me when I've spoken about what medical students can do to make their practice and their patient interactions more inclusive.
I think clinical judgment and also drawing on our intuition and wisdom in each clinical encounter is important. So yes, we have to consider the health and the health inequalities of minority populations, but equally, it's as important to consider and take measures to address the health of everyone. So I think if we think about the health inequalities of minority populations, we can't do that at the detriment of thinking about everyone.
I sort of was thinking about it in a way that's similar to like in clinical examination, asking someone if they use recreational drugs or if they use if they're smoking. Like there is a small percentage of people that would say yes to that, but I don't think generally patients would be offended if they're asked that because they would understand like the reasoning. Like we do have to ask even if you're not part of that like specific community or even if it doesn't specifically apply to you. It's just still something that we would want to include in like the protocol just to make sure that we're making it sort of more inclusive for like everybody.
So I recently came across a case study actually while I was doing some research for this episode, and it's a fictional case and it's used to help medics, particularly medical students, learn about being inclusive practitioners. And the case was around a young trans man who presents to the emergency department with severe one-sided abdominal pain. The medics in the case are trying their best to be really affirmative for the patient and really supportive, but due to this, it takes them longer than it should really to ask some of the relevant questions, particularly in regards to the patient's sexual history and menstrual history. And this is because they were worried about ensuring that they were approaching the situation sensitively and not offending the patient. It actually transpires in the case that the patient has an ectopic pregnancy, so it really does highlight the importance of healthcare staff knowing how to approach history taking and examination for all patients in an inclusive way so that everybody can be provided the best care. As medical students, we are coached into being able to have difficult conversations with patients all of the time. And we know all the techniques of giving warning shots, of saying, I'm going to ask you some questions that are a bit more sensitive. I might ask you some questions that are a bit more uncomfortable for me to ask. I think we are generally really, really good at doing that. But I think there are certain topics that people just feel a bit more frightened of offending or upsetting people. And I think the way to approach it is just as you would approach anything else. Like, our clinical judgment is good, our decision making is generally good. Doctors are good at reading patients and situations and knowing when to ask which questions and how to do that. So I think just treating it like any other difficult question you might have to ask a patient is fine. And also, like, apologizing and saying, I might not have worded that in a way that's comfortable for you, but can you tell me what language would be more comfortable for me to use, and then I'll mirror what the patient uses. And I think just apologizing, I think patients are quite forgiving and know that sometimes we say things that don't come out right or we don't mean, and if we just say, I'm really sorry if that came out in a way that made you uncomfortable. There are clearly times where it is really important to know that your patient is trans, but then there's also times when it's not important to know. If somebody comes in to general practice with, a virus, it's probably not that important. But sometimes doctors can get really bogged down with the fact that a patient is trans and end up walking down that, like really easily walking into that trap of asking loads of questions about that and actually missing out on what the patient's coming in for. So I think it is just finding the balance of knowing when, it's appropriate to ask those questions and when it isn't.
Yes, I think it's so valuable what you're saying because it's so easy to get things wrong, isn't it? And sometimes as a result of that, I think there's maybe a hesitancy or a tentativeness around particularly gender identity at the moment because it's so contested. The whole issue around who can claim to be a woman, trans rights, and it's so easy to maybe sometimes use language in a way that people can experience as offensive or marginalizing. So, and we all get it wrong. So I agree with you. I think when we do use language that can be phrased differently and we realize it, to apologize and then ask the person, how can we maybe phrase it in a way that's more inclusive or appreciative and then move on.
I think I agree with what George has said as well. From my perspective as like someone from a minority background, in interactions and with clinicians, if I can see that the clinician is making an effort in terms of like the type of language that they're using and sort of that openness to learn what would make you more comfortable, it goes such a like long way. Like I know personally I would remember the consultation with like very positive feelings towards it, because even if someone doesn't fully understand the sort of idea or like seeing that they're willing to take a step towards your direction to try to understand makes a huge, huge difference.
Absolutely. And linking on to what you're saying, Judy, so if we think of ethnicity and race, so that question about where are you from has now become loaded and contested. But I think it's also because language shifts over time. So language isn't fixed, and the way people use language may differ over historic periods. And it's good that we are aware of that, that language is constantly evolving and shifting and changing in terms of what's regarded as acceptable, or maybe how people identify, um, or how people reflect their gender identity in language. And that language evolves as we go along. So it's good always, I think, to check it out with one another, and particularly with students in class, because often younger people are more kind of in tune with language as it's evolving or as it's developing.
Yeah, I think I definitely agree. And like in terms of like questions like where are you from and things like that, I think from the perspective of like someone who's not originally from England or not originally from Ireland, because I grew up in Ireland, I think the statement itself is generally, acceptable, but I think what people get a little like more upset over is the pushback, because oftentimes it's not just where are you from, it's where are you really from. So you've already given your answer, you've given your initial answer, and then there's that pushback of, well, no, that's not where you're actually from. So where are you really from? That sort of emphasis on the really is, I think, what gets people feeling much more like uncomfortable. So
I always answer when people ask where I'm really from, I'm always like, Birmingham Women's Hospital, what do you mean? That's where I'm from. I think you can
And
use
that's lovely,
humor, just
isn't
bounce
it?
it back on them and just be like, what? I don't understand the question.
I've also found, I don't know whether you guys have found this, but I found on placement, I think 'cause I'm aware of how loaded a question it is when you're asking someone where they're from.
Mm,
I think I quite like just caveating why I'm asking it. So it could be you've come in with an infection. I just want to know where you've been and
yeah.
what you could have been. Or I want to know where your partner's from because of risk of XYZ. I don't know. I think it just tends to make me feel a lot more comfortable in asking it to just say, well, this is why I'm doing it. Yeah.
I don't know, would asking where were you born just be like more like, because then they say like specific to the place and you're not like associating it with where they like, because I feel like sometimes people do say like the place and then they go on to explain. Like I would say, oh, I'm from Nigeria, but I grew up in Ireland. Like it becomes like a full sentence. So yeah.
What is the impact on healthcare staff themselves from some of those groups, from like minoritized groups that we've talked about? Does your work and research ever look at the kind of those microaggressions and the impact on staff working in the NHS or in healthcare more broadly at all?
Yes, I think microaggressions or experiences of discrimination or marginalization for staff and health professionals who work in healthcare can have an impact in terms of adding to people's experiences of stress in the workplace that might lead to experiences of maybe compassion fatigue over time. And if we try and address it to prevent it from happening, we can help people to stay well, improve their mental health and well-being in order to remain in work in health environments longer term. So I think consideration of health professionals' own experiences when they work in clinical environments are really important. And also for LGBTQ plus staff who might experience sometimes maybe microaggressions or discrimination from
Mm.
patients in clinical environments, just as maybe people from minority ethnic backgrounds also might experience maybe racism from patients in clinical environments.
I think it's interesting from my experience, because I've definitely experienced this both at the hands of other healthcare staff while on placement or within my job and from patients as well. And I find that the blow is harder when it's from staff compared to from patients. I've had patients in my previous job would constantly ask, "Are you a boy or a girl?" And I'd be kind of like, "Oh, do you want like the long answer or the short answer?" But I felt that didn't impact me as much as then a member of staff saying something that was outright kind of discriminatory towards like LGBT people to me or in front of me, because I almost feel like I want that united front with my healthcare team, that this person doesn't see me as less than because of my identity or because of a group that I'm, part of. So I find it harder personally to know how to respond when it's staff compared to patients, because I don't know, I feel slightly more forgiving in my interactions with patients.
Also, I completely agree because I think as well, I guess the difficulty is it's a public facing job, but the problem with staff is that as an institution, there's control over what the staff do and say and express. But I think then because we're obviously dealing with the members of the public who are going to have a wide range of views and backgrounds and so forth, it then I think also means that there's almost more tolerance in terms of attitudes of the staff as well, because it then seems to be seen as something that comes as part and parcel of the job, is that people are going to be dealing with discriminatory behaviour in a way that I really don't think should be the case. But I think as well, people are kind of somewhat like some of the doctors that I've spoken to as well, they're just kind of attuned to the fact that they are going to be dealing with racism and transphobia and blah, blah, blah. And they kind of, I think, almost lump together the institution alongside the public in a way that I think I completely agree, George, it shouldn't be.
Yeah.
Yeah, no, I can imagine that it is quite tough, especially if it's your team, because you're supposed to kind of have that united front, as you said, and sort of be like working together to like help each other. And I can see why it would potentially be more difficult than with patients. Sort of like because you see your staff members and like your colleagues as someone to help you out if things do get difficult with patients, someone to step in. So to then feel like the people that are also supposed to be supporting you are not sort of understanding you, I think is particularly painful.
I just want to talk about two things, and that's firstly, LGBTQ plus staff. If we come out in clinical environments, I think it can be really helpful in order for people to be visible. So health professionals can support one another in the clinical environment. And then there might also be allies in other members of staff that can help fly the flag for LGBTQ plus people, but also role modeling. So I think in university environments, but also in clinical practice, if people are out and they're visible in terms of their gender identity and sexual orientation, or we haven't even spoken about sex characteristics in
Mm.
terms of intersex people. If people are out and open, I think it creates opportunities for conversation and for mutual understanding, so we can address experiences of marginalization or discrimination when it occurs in practice. So if people, for example, wear a little badge with a rainbow flag or something similar in clinical environments, I think it can be really helpful, because then people know it's an LGBTQ plus friendly environment and people can feel safe in that environment. There's also good resources on the European Commission's website, and also some of the voluntary sector organizations, for example, Stonewall or ILGA Europe, or organizations like Drinkaware, have research findings and also literature that might be useful for people if they wanted to read more about how to create an inclusive environment for LGBTQ plus patients and service users, but also staff.
It's interesting what you just to go back to, you mentioned, we hadn't touched upon kind of intersex patients at all, but that's definitely something that I don't think gets taught at medical school. And I've definitely had people say in their final year of medical school to me, I don't actually know what intersex means. And I think there is this conception amongst medical professionals widely that intersex traits are rare, so we don't need to learn about it. But I would argue that there are lots of very rare things that we learn about in medical school that often we're told you'll probably never see this in clinical practice, but you need to be aware of it, you need to know about it. And I would argue that you're probably much more likely to come across somebody in practice who is intersex. And I definitely think that is a bit of an oversight in medical curriculums.
Absolutely.
I completely agree. I think the main teaching that I've had about it, which again has really stuck in my head, was with regard to descended testicles in babies, that if it's unilateral, it's fine, you don't need to worry. If it's bilateral, or they could be intersex, it's an emergency, we need to rush quickly to like try and give them a gender ASAP. And like that's been about the limit of it, which I think as well, it's like obviously again, people are trying to do the best for these babies to try and get them to fit into what they see as the correct norms. But I think as well, there's obviously so many assumptions involved in just that little tiny guideline that I've obviously memorized for my exams that I just think shows so much, I think, about medical kind of assumptions to do with gender.
Yes. Absolutely. I think there's a lot of space for us to have more open conversations, um, to help foster understanding of the challenges intersex people might face in health environments. There's a lot more work that can be done to develop understanding and awareness of intersex people and their lives and their health concerns in curricula, in educational environments.
I think during the conversation, we did touch on the fact that sometimes senior members of staff have quite solidified ideas about LGBTQ plus communities, as well as sort of certain minority ethnic groups. At the moment, I study abroad, so these ideas are still quite rigid. So like wondering, like, what could really be done about that? Like, is it something that students sort of just accept as like part of like clinical years and you're going to be meeting people that are much older who have like certain ideas, or is there a way for the conversation to also include sort of like the older generation of doctors?
I I think it depends on how well you know the person and how long you're in placement with them for. I tend to try and find somebody else who is senior who might take a different view and use them to challenge the viewpoint, because if you're quite junior, they might not. I think we all know on placement there are times when you don't necessarily feel that respected as a medical student and that your opinions aren't really that respected, or you're seen as a little bit naive. So I would probably try and find resources for them that they can read more about it, or signpost them maybe to somebody else who's of a similar level to them in terms of the workforce, who might have views that oppose theirs or might be able to challenge them. Um, or I guess if you feel comfortable challenging them, saying, "Oh, but have you thought about it in this way?" I think it's approach. I think it's just having open conversations with people in a way that feels approachable and feels like you're not kind of going all guns blazing at them, saying that they're wrong. I think it's just having a conversation, and I'd hope that most people would feel, you know, would be respectful and would want to have an open conversation with you, because I think these things are interesting to to speak about.
Is it something that, you know, if students notice, is it something that they can report, or is there like any system around that? Sort of to take away the pressure of like feeling like you're the one that has to educate like more senior staff members about it. Is there any sort of protocols that you can follow to like maybe make a note of it or flag it up, especially if you've noticed it consistently?
You can definitely report to your university. I would definitely recommend reporting it to your university, if you're a medical student. I don't know, Letitia, if you can think of any other like official avenues to report staff members who are consistently kind of voicing, discriminatory views.
Maybe two angles. I agree with you, George, in terms of universities have procedures. So at the university where we work has a procedure called Never Okay, where you can then flag up if you've experienced discrimination in the workplace. And then the university deals with it in terms of investigating it and trying to put corrective measures in place. And then also clinical practice environments often have a process by which staff can flag up experiences of discrimination and marginalization, which then also investigated, and then people might make recommendations for how those experiences can be addressed. But I think it's also important that people are emotionally supported. That if people do experience discrimination, that there's someone they can talk to that can provide emotional support.
I think things are changing quite a bit, and like we are like sort of becoming more aware and like having these conversations. So I think that is quite like a positive thing to like look forward to in like the future and like future practices.
I was going to say that I think it's exactly conversations like these that can then help equip students and future doctors to feel more uncomfortable and more inclusive. So hopefully this is the beginning of people feeling more comfortable asking and supporting and being allies.
Absolutely. And more broadly, I think an understanding of diversity can really help bring more varied perspectives to clinical practice that we can all benefit from.
I think that's all we have time for today. Thank you so much to our panellists for joining us and to everyone at home for listening to this episode of Sharp Scratch. If you like our show, I'd love it if you could support us by leaving a review wherever you get your podcasts or sharing it with the people you know. You can find us on social media, BMJ Student on Twitter and Instagram. You can also find clips of the episodes and more over on Sharp Scratch Pod on TikTok. If you'd like to hear other episodes, subscribe to Sharp Scratch wherever you get your podcasts, and in 2 weeks' time, you'll be notified of our next episode. Until then, it's goodbye from us.